Other malignancies that we're going to cover now and that will show up on the exam, the Wilms tumor. This is a very common one on the exam, and we've referred to it on several occasions already. The Wilms tumor is also known as the nephroblastoma. Do not confuse that with the neuroblastoma that we're going to discuss shortly. The Wilms tumor is the second most common malignant abdominal tumor. Usually it can present as an abdominal mass. Many times the mom is bathing the baby and it's an asymptomatic abdominal mass. She just palpates something. Or the child comes in for a health supervision visit and the physician palpates something, and then workup is started. It can affect one or both kidneys, but mostly just the one kidney, thank goodness. Always remember your association of aniridia and hemihypertrophy and a Wilms tumor. They can also have other genitourinary anomalies, but remember that association. It can be just a painless abdominal mass. Sometimes you can see hematuria. Sometimes they can have hypertension. But typically it'll be an abdominal mass that's just palpated during bathing or during routine physical. The diagnosis, the abdominal CT scan is the best way to diagnose this patient. Patients, for example, with Beckwith-Wiedemann are at higher risk for these abdominal masses, and so they will have screening with ultrasounds every 6 months. You don't want to have the radiation. But if you suspect this mass now, the best thing to do is get an abdominal CT scan. A chest x-ray is also helpful because sometimes patients can have lung involvement and can actually develop pleural effusions too. The staging is listed there. Stage 1 is confined to the kidney. Stage 2 is in the kidney but now goes past the capsule. Stage 3 means that there's something left after it's removed but still confined to the abdomen. Stage 4, we're talking spread both sides of the diaphragm, and stage 5 is both kidneys are affected. Again, you probably don't need to spend too much time on the staging. Here on abdominal CT, you see an enormous Wilms tumor. You need to remember, since it is a nephroblastoma, it is coming out of the kidney. It is from the kidney as opposed to a neuroblastoma. On the exam, they will try to confuse you. We'll discuss the differences in a second. Treatment of Wilms tumor is try to remove it, number one. Usually that's all you need to do. Patients may need chemotherapy and radiation therapy. Certainly if it's inoperable, you'll need that. Prognosis is pretty good depending on the staging, however. The neuroblastoma arises from the neural crest cells. So the neuroblastoma has a much wider distribution than the nephroblastoma. But on the exam, they might very well put the neuroblastoma in the abdomen. It commonly can present there, and they'll put it there to confuse you with the nephroblastoma. If it's in the abdomen, many times it'll be from the adrenal glands, and it'll be sitting on top of the kidney as opposed to a nephroblastoma, which is arising from the kidney. So try to keep those separate. It's the most frequent cancer of neonates, the neuroblastoma. Typically, though, it tends to resolve on its own in the first year of life. And so the ones that we see are later on in life, usually at around 2 years of age. Very common in the abdomen, and again, for exam purposes, they might put it in there just to confuse you, and you'll see it arising from the adrenal glands. It'll present as a mass, which is palpated, and so there's your differential diagnosis. Neuroblastoma, nephroblastoma, they're both in the abdomen, they're both palpable masses. Get a CT scan. Sometimes you can get calcification and hemorrhage. The neuroblastoma can also present, however, in the chest, and it can present in the neck, anywhere that there are neural crest cells. It's spread commonly to the long bones and to the skull, also to the bone marrow and other organs. Part of the evaluation of a patient with neuroblastoma is going to be CT scanning of the entire body. Also look for neurologic signs and symptoms. With neuroblastoma, they talk about opsoclonus, myoclonus, or the dancing feet, and that's some of the neurologic manifestations from neuroblastoma. A CT scan is very helpful to evaluate where the tumor is and any extension of the tumor. Tumor markers can be drawn, and the neuroblastoma will have increased HVA in the urine, as opposed to, we're going to discuss the pheochromocytoma in a minute, and we're going to look for VMA there. So try to keep them apart. You can also do a bone marrow, and you'll see neuroblasts in the bone marrow. All patients need evaluation for metastasis. The staging of the neuroblastoma is stage 1, it's in that organ of origin. Stage 2, beyond the organ but not across the midline. Stage 3, beyond the midline, and stage 4 is widespread. Treatment, you try to remove it, and chemotherapy, radiation therapy. Failure of that management will then lead to the decision of bone marrow transplantation. The pheochromocytoma is not as common in children. It is a catecholamine secreting tumor, so a lot of epinephrine is being secreted. It is going to be in the adrenal medulla most commonly, but along the sympathetic chain, anywhere along the sympathetic chain, you can have a pheochromocytoma. The typical age, and it's important to know the age of the patient when you're reading the test question, around 6 to 14 years of age, more common on the right. It can run in families as it is an autosomal dominant inheritance. There are some associations with other syndromes or sequences, such as neurofibromatosis and the multiple endocrinopathies that can be seen at some points. The presentation, these patients will have hypertension, really high blood pressures. Now, we talked about hypertension on a previous chapter, and we said that most causes of hypertension in children will be renal, but this is a different cause. Here we have a patient with a pheochromocytoma, and it's a sustained hypertension. They can have palpitations. I know of a girl that was as a teenager, and she presented with palpitations for several months. She had an extensive cardiac workup and was placed on beta blockers. She then began complaining of abdominal pain. The next part of the slide there, she started complaining of abdominal pain, and a CT was obtained which showed a mass in the belly, and then we went along the line of examining her, working her up for a pheochromocytoma. These patients will have hypermetabolic states secondary to all this catecholamine release. They can have papilledema, but look for sustained hypertension. They can also have flushing and or pallor. The labs, you will have, you can get urine levels of catecholamines and the metabolites like metanephrine. In children, look for increased VMA in the urine. And that's the urine VMA or catecholamines is the best test because you may not pick it up on blood. So the urine gives you a better sample. Remember that with neuroblastoma, you have the HVA is what is elevated. With pheochromocytoma, it's the VMA that's elevated. Also, with neuroblastoma, you really don't have hypertension. A CT scan is then done to delineate the mass, and you can do the MBIG scan, and that tracer is picked up by chromaffin cells, and the pheochromocytoma will light up and let you know exact location of the tumor. The treatment is removal of the tumor, but this is a tricky operation because the patient will have a major release of catecholamines as you manipulate it. So these patients need to be preoperatively placed on medications that will calm down the epinephrine response, and then during the surgery they need to be monitored very closely, and for some time after the surgery they need to be monitored closely. Once the pheochromocytoma is removed, the blood pressure should return to normal. You do have to follow up and make sure they don't have new tumors. The rhabdomyosarcoma is a soft tissue tumor, and the site of presentation determines the symptoms. 40% are in the head and neck. These can present as just a mass. They can present as nosebleeds. If it's in the nose, they can get bleeding there, so epistaxis. I remember a child that had one in his mouth, and he just kind of basically, he felt it in his mouth, so he kind of chewed at it, His mom wondered why he was chewing that all the time, and she looked in there and she saw a mass and brought him in. That was one in the mouth. So it depends upon where the tumor is located, that the symptoms and signs that you'll see. In the genitourinary tract, you can see sometimes hematuria. When we talked about sarcoma botryoides, you'll see a grape-like mass protruding from the vagina. In the extremities, it could just be a mass that you can palpate sometimes. There is an increased risk of rhabdomyosarcomas in patients with neurofibromatosis. And you need to determine, there's different types of rhabdos, and it's all determined via histological exam. They're broken down into the embryonal, and that is where the botryoid tumor will be found. This is a grape-like cluster. It can be found in the vagina, in the nasopharynx, and it really does look like a bunch of grapes just protruding from whatever site. Alveolar tumors have a poor prognosis. The pleomorphic tumors are more of an adult onset. Again, clinically, they can present as a mass, and the mass location determines other presentation. The diagnosis depends on the site, but certainly you can use a biopsy, MRI, CT scan. If it's already sticking out, then you really don't need to do all those, but that'll be part of your workup to look for extent of the tumor. The treatment, the tumors that are completely resected do the best. Unfortunately, tumors can't always be completely resected, and so those patients will have to have chemotherapy and possibly radiation therapy.